Welcome along. It's just gone past 12:30, so I am going to keep motoring along as I know we all have busy lives, and hopefully we will hear from a few more people over the or we'll get a few more attendees over the coming minutes. So I would like to welcome everybody to I guess the second webinar in our series of Get Rare Aware webinars, brought to you from Rare Diseases Ireland in partnership with Roche. The webinar is being recorded, just for your information, so that everybody knows that. And for people attending, there is a Q&A function. So if you have any questions that you would like to ask, please do ask questions through the Q&A function, and we will try to come to all of them over the course of this webinar. We have with us today Professor Ronan Leahy from Children's Health Ireland at Crumlin. Professor Leahy is an immunologist and has, I guess, detailed knowledge of the newborn screening system, having worked hard and advocated hard to get some conditions added to the screening system, and has experienced, I guess, some of the delays in expanding the heel prick test for newborns in Ireland. So I will come to Ronan in a couple of minutes and ask him or introduce him at that stage. So what is the Get Rare Aware campaign? This campaign is really primarily about getting rare diseases front and centre for the political classes in this country, be they TDs, be they senators, be they MEPs. We really want, I guess, our political elected representatives to know more about rare diseases, to think rare whenever they're considering any policies or making any decisions or anything, and to advocate, I guess, on our behalf at the Oireachtas, in the Dáil, with government, and at a European level for the rare disease community. And I link into the European piece because, you know, rare diseases, individually rare, but across Europe, we coordinate. I guess we rely on some European expertise to provide maybe expert care in this country, and also to coordinate some of the research and education right across Europe. That has been identified as being the best way of, I guess, dealing with some of the challenges associated with rare diseases. This is the second year of the Get Rare Aware campaign. Last year, we had considerable success with the campaign, with over 6,000 emails sent to some of those elected officials, to the TDs and senators primarily, and asking them then to follow up with government. So there was over 50 parliamentary questions posed to the Minister for Health around last year's campaign topic, which was around genetic services and the availability and access to genetic services for people living with rare diseases in Ireland. That topic is still ongoing, I guess. Most recently, I think there was leaders' questions in March, so just a couple of weeks ago, on the topic of the genetic strategy and provision of services, and of laboratory space for genetic services for people living with rare diseases. So, it is a campaign that has worked, we've had success with, and we really want to build on that success this year. Hopefully get more politicians involved in the campaign, and making them more aware of the rare disease community in general. The theme for this year's campaign is around newborn blood spot screening. It's more commonly known as the heel prick test, and all parents in Ireland would be aware of the heel prick test. The system that we have today tests for about 9 rare diseases, and it is this huge, enormous uptake. It's a really successful system, and it eliminates that diagnostic odyssey for people living with rare diseases. Over 30%, something on the order of about 37% of people are waiting 5 years for a diagnosis of a rare disease. Obviously, if you can capture newborns at that phase and screen them for some of these rare diseases, they will be diagnosed essentially at birth and be provided access to treatment and care that could transform their lives. There are new therapies coming on board. There are new modes of treatment and stuff that in some instances are potentially curative. So these children will never develop symptoms for some of these rare conditions, and so enabling the newborn screening system to expand, to add more tests for some of these rare diseases, where therapies are coming online, where there's research being conducted. This will really transform the lives of those affected individuals and their families. Today, the burden on families is enormous, particularly during that diagnostic odyssey when you're not sure, why is my baby or my newborn sick? What's going on? All of that questioning. So the screening system can help to eliminate some of that and get people access to the expert care that they need. Today, as I mentioned, there's about there are 9 conditions tested for in the newborn screening system in Ireland today. We are well below our European counterparts. 75% of European countries test for more conditions than we do. Some countries are testing for up to 30 or 40 different conditions. So clearly there is more that we could be doing if we could expand the existing system. There are, in fact, submissions in to add another 30 plus conditions to the newborn screening system in Ireland today. The system itself I would describe as being a 2-step system. The first step is where the National Screening Advisory Committee, so an offshoot from the cervical checks scandal. So the advisory committee, this National Screening Advisory Committee, will assess different conditions and say whether or not they should be added to the newborn screening system. They also look at the cancer screening services and other screening services in the country. But in terms of newborn screening, they will make an assessment on individual conditions and say whether they should or shouldn't be added. And that assessment will look at, I guess, the technologies that are available, the treatments that are available, the ethics around, can we access, is there the right care available in the country? So there's lots of, I guess, different pieces that they make their determination based upon. The second piece then is, once a determination has been made that something should be added, it then goes into the HSE. And that really is, I guess, where we are calling today for additional resources. So there is I guess, resources available in the newborn screening system today, but they're running and maintaining the existing system. They're keeping the labs up and running. They're making sure pathways are working and that children are being referred into the best expertise in the country for the conditions that are screened for today. But really, to expand the system, to add those 30 different diseases that have been asked for, we need resources to allow that expansion to happen. You don't just, I guess, flip a switch. There's a lot of work that needs to go on in the background in terms of the lab itself and their capacity to add testing or to do testing, and also in terms of pathways to ensure that children diagnosed right across the country will be referred into the correct expertise and will get access to treatment and care as soon as they are diagnosed. So that's really what we're looking for today, is that ability to expand as recommendations are being made by NSAC, that we can expand, we can implement those recommendations in a timely fashion, as those recommendations are being made. There are, I guess, I've probably been through most. I think I've covered most of the points that I'd like to. So at this stage, I might bring in Professor Leahy, Ronan. There, lovely. Thank you very much for joining us today, and I really do appreciate you taking time out of your busy schedule to be here to talk with us a little bit about your experience with newborn screening. But I guess maybe we'll start with, do you want to give a little bit of background on yourself and what you do?
Sure. Thanks, Vicky. Thank you for inviting me, and thanks to everyone for listening. So I guess I'm a pediatrician, first of all. Trained I went to medical school in Galway. Then did a good bit of pediatric training in Dublin. And then I went to Canada and did a fellowship in infectious diseases. Came back to Dublin, did a PhD, and then went to the UK and did a fellowship in immunology and transplant. So then after that, I was appointed as a pediatric immunologist. So kind of spanning immunology and infectious diseases, and in particular looking after patients who have problems with their immune system. So that's my main responsibility.
Okay, very good. Um, so you, I know, have worked very hard over a number of years, much longer than I've been thinking about newborn screening, I suspect, over the last, maybe 8 or 10 years, seeking to have, I guess, ADA SCID, so SCID, severe combined immunodeficiency, so where children's immune system isn't working properly, to get this added into the newborn screening system. Why? What is it? Why would newborn screening, I guess, help for these children?
Sure. So just I guess I appreciate that not everybody would know necessarily what SCID is. So I might just spend 2 minutes just
Yeah.
explaining what SCID is first. So I guess when we talk about our immune system, your immune system is what protects you from bad things like infections and cancers. And your immune system works by discriminating your own body cells from cells that are foreign, like infections, or weird looking, like cancers. So your immune system is made up of organs, cells, and molecules. And patients with severe combined immune deficiency, they're unable to make a particular group of immune cells called T cells. That's the crucial thing. They can't make T cells themselves. And you can have SCID for a variety of different reasons, usually related to mutations in genes. So those of you who have children with rare diseases know that very often rare diseases have a genetic basis, and that same is true for SCID. SCID is a rare condition, and SCID just happens to be due not to mutations in one gene, but to mutations can be due to mutations in about 20 or 30 different genes. So I guess when I came back from the UK, the first couple of years I kept seeing children with SCID arriving really, really sick. So children born with SCID, because they don't have a functioning immune system, they're fine at birth in the majority of cases. But then over the following weeks and months, they gradually pick up lots of infections, nasty infections. And because it's so rare, even really good, really experienced, really knowledgeable clinicians don't think of it or don't make the diagnosis. This is something that I noticed, is that my colleagues who would have been senior to me, maybe 15 or 20 years senior to me, who I would have really had a lot of time and respect for, even these really excellent clinicians, just because it's so rare, they don't diagnose it. So around that time, more and more literature started being published about screening for SCID on the heel prick. And there were two techniques. One, which allows us to detect ADA SCID, which is convenient because ADA SCID just happens to be the commonest type of SCID we have in Ireland. And then a more complicated technique that allows you to screen for all the different types of SCID, so SCID regardless of the genetic mutation. So I guess I started seeing all these children coming in a really bad condition with SCID, and coming in a bad condition reduces their likelihood of having a good outcome after transplant. So bone marrow transplant or stem cell transplant is the treatment modality for the majority of types of SCID. So that's what motivated me to try and get it on the heel prick program.
Okay, very good. And when you do, I guess you now have ADA SCID. ADA SCID has been approved and implemented in Ireland. I think it was implemented almost 2 years ago, I guess. May 2022 was when it was started. Um, what difference does it make now that now that you're finding that those children before they're coming into you sick, essentially? They're coming in well, I
Yeah.
guess is how we would describe it, yeah.
Yeah, so it makes an enormous difference. So I'll just talk about ADA SCID first, I guess, because it's a very particular subtype of SCID. So ADA SCID is an interesting combination of a metabolic disorder and an immune disorder. So ADA stands for adenosine deaminase. It's an enzyme, and if you lack the enzyme, you get buildup of toxic metabolites. And it just so happens that these toxic metabolites affect the immune cells,
Okay.
the immune cells that are so important, and the lack of which lead to SCID. So patients with ADA SCID present just like other patients with SCID with lots of infections. And if you don't diagnose them on time, the infections can be very harmful. So they can get, for example, meningitis or encephalitis, so that even if you cure them with transplant, they can be left with damage. Uh,
Hmm.
so, so having the test on the heel prick allows us to diagnose these infants, number one, before they get any infections. And number two, there are other complications associated with ADA SCID that are not infections. Uh, and the good thing about ADA SCID is you can actually start enzyme replacement therapy. So while the curative treatment is transplant, while you're waiting for transplant, while you're getting your donor ready and all that stuff, before that, you can start the patient on enzyme replacement therapy, which is given as an injection intramuscularly once a week. So once we found or diagnosed our first patient a few months ago, the first thing we did was we brought her into hospital. We put her in isolation. We put in all the precautions to stop her getting infections. And then we started her on enzyme replacement therapy, which the combination of all these things have really got her into a very good condition. And in fact, as of Monday, she went to the UK to get her transplant. So,
And,
uh, so it's made a big difference in that case.
and in the intervening period, was she hospitalized, or was she able to
Yeah.
go home?
So it was actually very lucky that we diagnosed her so early, because one of the complications we see in ADA SCID is an inflammatory pneumonitis. And it
Okay.
turned out that she, for reasons we don't fully understand, she got it quite severely. So the enzyme replacement therapy was particularly important for her. So if her diagnosis had been delayed, I think she wouldn't have done quite as well. So
Okay.
she's doing really well. She's in excellent condition going into transplant. Obviously, the transplant is not risk-free, but I think her prospects of coming to transplant in good condition are much better now than it
Yeah.
would have been had we just diagnosed her symptomatically.
Yes. Yeah. 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 It must be very pleasing to see all of your advocacy work actually coming to effect now, and to see the impact that it will have on your patients, I guess, into the future. So just in terms of, I guess, the system as it is today, I would just talk a little bit about NSAC, the National Screening Advisory Committee. I believe that you had been pushing many years to get SCID and ADA SCID added to the screening system, but there wasn't really, there was no authority there to say, yes, we'll do it, or no, we won't do it. And that, everybody's saying, oh, it's somebody else's job. But now there is. So at least, maybe there's a benefit to having NSAC, I guess, that at least there's somebody responsible for making these decisions. Am I correct in that?
Yeah, so I had, as I had shortly after I got back around 2013, 2014. So almost immediately I started looking at this because I could see it was being implemented or being implemented in other countries. So I initially presented our experience, because the first thing I did was started collecting all of our data, looking back at all the cases we'd seen. And I presented some preliminary data to the Newborn Screening Committee initially back in 2015, 2016. So that was before the NSAC was established. So actually, the application for ADA scale, I got approved before NSAC.
Yeah.
So we had done so much work ahead of time that the feeling was that it would be unfair to wait until NSAC was established before getting approval for ADA skid. So the ADA skid was actually approved before NSAC came online. But we felt that for our next step, the next step that we're trying to get over the line is to get screening for all types of skid, which involves a different technique called TREC analysis, which is a PCR-based assay. So because that's much more involved, it would involve a lot greater investment of resources, time, staff. We did take that application through NSAC.
Yeah.
So that was, I spoke to the other members of the screening advisory committee or the National Newborn screening committee about that, and that was the decision we made, that that was the best way
Yeah.
to get that going. So before we brought it to NSAC, we did, I suppose the thing, I guess we did a lot of work really on trying to make the case, or trying to get all of our data together. So we put in a request to the HICWA to undertake a health technology assessment on Trek screening for all types of kids. So we're trying to make the economic case to include Trek screening, because I think ultimately, our thinking was that our politicians who make these decisions, and the Department of Health who makes these decisions, I guess they have to be able to justify it to the taxpayer. So having an economic case to show that it's cost effective, and that the benefits of introducing such a screening program are cost sufficient and cost effective, we felt that would make our case much stronger. So that's what we did first. We did the health technology assessment first, which showed that it would be cost effective to introduce it. And then I think it was much easier to get it past the National Screening Advisory Committee.
Yes, yeah. Everything had been assessed, and all of the ducks were in a row, I guess, at that stage. I just do a quick reminder to people that if you do have any questions for Ronan or for me, please do type them into the Q&A function. So I guess when you're presented now with children, if somebody comes into you sick, I'm like, does the fact that they have gone through newborn screening, does that presumably changes your approach to how you assess, somebody that's coming in, maybe a 1-year-old that comes in today that appears to be very sick. How does that change how you will manage that patient now? The newborn screening, I said they don't have ADA skid. Does that relieve you of, or does that speed things up for you, or do you always have a query in the back of your mind? I wonder, should I still be chasing this other thing, even though I know they've been screened for it? How does that change your practice?
Okay, so I guess the ADA skid represents about 50% of the skids that we have seen in Ireland. We went back over our data. We looked at our data for about the 15 years before around the time I came back. So we went back, we looked at all of our previous cases, and we published them. So we put all of the cases together, we published them in a journal, and that's, you can look it up. And
Yeah.
so that was very helpful. So I guess I know that if I have a small baby who's getting lots of infections, who looks really sick, I know now that they don't have ADA skids. I can be sure of that. But what I don't know is, do they have skid due to other reasons?
Yeah.
So in many respects, a 6-month-old or a 7-month-old who comes into me with failure to thrive or lots of infections, I still don't know for sure that they don't have SCID. So realistically, I guess it doesn't change. It doesn't change my practice from that perspective. I still have to think about SCID
Yes.
in children. I just know that they don't have ADA skids.
ADA
That's one
skid.
thing they don't know. Yeah.
Okay. So it doesn't, I mean, I guess you wouldn't have done ADA skid first and then other skids. You would have done everything in parallel anyway.
Correct.
So
Yeah,
even though you've
exactly.
ruled one out at the outset. Um, so when you get there's an application in, or not even an application, skid has been approved
Hmm.
for implementation, but there's a delay with the implementation, and in part because we're waiting till the newborn screening lab is moved to the new hospital, and all the appropriate pathways are put in place. Those children then that are presenting today, I'm like, that'll be the end of it. Can you go to bed easier at night now? I guess, what impact will it have on your clinical practice? And how many children were you seeing with SCID and ADA SCID typically?
But thankfully, both conditions are rare,
Yeah,
but we would typically see about one or two a year. So
yeah,
one or two every year, and that's still the case. So we had an ADA skid this year, and then we had a non-ADA skid in late 2022. So they're a bit like Dublin bus. You might get none for a while, and then you get two or three together.
Yes, yeah, yeah,
So,
yeah,
so I guess as it stands, as I said to you, I still can't be sure when I see a small baby whether or not they have skid. Um, I guess the hope, like, we're obviously really hoping that eventually uh, the track screening will be introduced so that we will be able to determine whether or not all skids can be identified early on, and that'll be a big help for us for sure.
yeah.
And I guess the important thing is that it'll make outcomes better for the children, because we know that if you identify a skid early before he or she gets sick with infections, that survival post-transplant is much higher. So
Mhm.
if you're screened and identified early and you get to transplant without any active infections, your survival rate is 95% or higher. Whereas if you're not screened and you go into transplant late with an active infection, your survival rate drops to less than 70%. So
Okay.
that's a big difference. So,
Yeah,
I mean, in the meantime, we're not doing too bad, and we're lucky that we've a good relationship with the transplant team in the UK, in the Newcastle, who do the transplant. So we're lucky in that respect.
yeah,
But I think introducing Trek, which we hope will happen, as you mentioned, when we go into the new hospital, I think that'll be very helpful for improving outcomes for our skate patients and also for a number of other conditions. Interestingly enough, the Trek screen doesn't just pick up skate, it can pick up other significant immune deficiencies as well. So it'll be useful for a variety of different reasons.
okay, okay. And for those other immune deficiencies, is transplant the pathway for them as well, or are there
Yeah,
other?
transplant would be the intervention, I guess, that would be most commonly used for severe T cell deficiencies,
Yeah,
for SCID. And then there's also a possibility you might pick up children who have congenital problems with their thymus. So
okay,
the thymus is an important organ in the front of your chest. That's very important in how your T cells develop. And children with extremely underdeveloped or absent thymuses can actually have a thymus transplant
okay,
done in London. So they've introduced track screening in Germany. They presented their data at a conference 2 years ago. So they'd managed to pick up 4 or 5 kids that they referred to London for thymic transplant. So that represents an opportunity as well for us to pick up very rare thymic defects.
yeah,
So track screening certainly holds a lot of promise, and I think it will definitely help those rare cases that we see.
yeah,
Now, I know, as I mentioned, you had asked me how often we see a skid case. We see a skid case maybe once or twice a year. And looking at international figures, you'd expect to find a significant T cell problem in about 1 in 20,000 cases. So you'd expect maybe 2 or 3 of those a year.
okay,
So
yes,
we're
yeah.
hoping that once Trek comes in, we'll be picking up 3 or 4 kids
Cases a year.
ahead of time before they get sick.
Yeah, yeah, yeah. That would be amazing. That would be absolutely fabulous. So it would. Very good. Is there any questions out there? It's a smaller crowd today than last week, but if anybody does have any questions, please do ask them now while we have the expertise of Ronan available to us. It's good to hear on the ground how these things really work. I was going to pose a question, or ask a question, just in terms of the transplant. I'm like, is that largely curative now that, these children will lead a relatively healthy life and they'll presumably be in and out in terms of just monitoring and whatever, but they wouldn't be expected to get sick anymore? Is that a reasonable statement to make, or am I overstretching?
Yeah, so I would say the vast majority of children who with inborn errors of immunity go to transplant do well.
Yeah.
So you're talking about certainly survival figures of above 90% or
Okay.
85 to 90%. So if you look, I think at Newcastle, their overall survival rate is about 90%.
Okay.
And most of them would do well and would not need that much beyond any other kid in terms of ongoing care.
Okay.
So
Yeah,
those
yeah,
who
yeah.
do
And
well,
will lead long lives and
yeah, those who do well do really well.
yeah,
There's obviously, like as I mentioned to you before, transplant is not without risk, so there is
yeah.
a mortality, probably somewhere between 5 and 10%. And then some kids are left with a few problems afterwards. They can have maybe autoimmunity or
Okay,
have kind of partial restoration of their immune function. But
okay, okay.
the vast majority of kids do really well.
And for those that are in that kind of like maybe partial restoration, is part of that because their immune system has been so damaged by the conditions or by the, by what's happened before they got their diagnosis and treatment, or is that just going to happen no matter what?
Yeah, so certainly if you go into transplant in a poor condition, that definitely affects or reduces your likelihood of having a good outcome afterwards. So that's what
Yeah,
we're trying to avoid by screening.
yeah,
So definitely going into transplant without any active infections really improves your outcome. So
super. Yeah,
that's certainly
great.
true. Um, but I think even in the best circumstances, sometimes a child can be unlucky. So sometimes
Yes.
something bad may happen, a procedure can go wrong, or you might just get bad graft versus host disease. So occasionally a kid can be unlucky, but for the vast majority of kids, it's curative. You know, it really is curative. It transforms their lives, and
Yeah.
for the vast majority of kids, they can live a long and healthy life.
Super, super. It's amazing when you hear that type of stuff, that something that seems so simple that actually is
Mm.
already happening from, the child's perspective. There's already the sample being taken, so it's not any more invasive, but can actually lead to these amazing outcomes. Um, I guess I'm not seeing any questions coming in, so I think we're in for a shorter webinar today, which is great. But before I let you go, Ronan, just in terms of, I guess, the future and newborn screening. I mean, we touched on it very briefly earlier on. The I guess the advent of genomics and things like that. But um, where else do you see newborn screening going from your medical practice? Are there therapies coming up down the line that you kind of like, if that therapy gets approved, we'll need screening and things, is this, I guess, one of those things that when I spoke recently, say with somebody from the European Medicines Agency, they were saying it's great having a therapy, but if we can't diagnose them properly, it's, the therapy is not much good to us. Are there things happening there that you're saying I will need newborn screening in other areas, or is it all going to be, do you think, down to genomics into the future?
Yeah, I mean, in terms of new therapies, I guess there's certainly a lot of interest in gene therapy going forward. I
Yeah,
know it's already in place, I guess,
for
for
SMA.
for SMA
Yeah,
for
yeah.
sure. Gene therapy, we've had a few patients go through gene therapy for ADA skid,
Oh, really?
and they're
Through a trial, or is there something approved for ADHD skid?
through a trial in the
Okay.
UK.
Yeah.
And there is a ADA gene therapy approved for ADA skid in Italy.
Okay.
If you don't have a good donor mass.
Yeah.
So gene therapy, I think, will become more and more applicable as years go by. I think there's certainly a prospect of gene therapy. Robin gave an excellent talk to us a few weeks ago about gene therapy for hurlers. So I know that's a rare disease that we see a little bit more often here in Ireland than we see in other countries. So I think in terms of therapeutics, gene therapy and gene replacement and gene addition, adding technologies will become more and more widespread.
And
And I
again,
think
you'll want your children to be as healthy as possible going
correct,
forward,
yeah,
just
exactly.
like
All of
the
these
family.
things they'll only work if the kid is in good nick beforehand.
Yes.
So that's very important. I suppose one thing that I should mention is at the moment, as you know, we're sending our kids to the UK for transplant for inborn errors of immunity, inborn errors of metabolism, and hemoglobinopathies. We'd like to start doing these transplants here in Ireland ourselves, and I think it'll be, once we get into the new hospital, that'll be a real opportunity to
Yeah.
expand the transplant service. So at some point we may be asking for your support to help us
Get that one over the line.
get that over the line. Yeah,
Yeah,
exactly.
yeah, yeah. Well, I will have to say I did observe the HIPAA report coming through last year. I think
Mm,
it was saying we really should be doing it in Ireland, that actually
mm.
the cost effectiveness, from the financial standpoint, it makes absolute sense. And clearly from a family's perspective, not having to uproot and move country for a couple of weeks or a couple of months, particularly with other family members and stuff, that's
Mm.
very disruptive on families. So I think we would be all in favor of those types of services being repatriated, if it makes sense, definitely,
Yeah,
definitely.
so we're, just so you know, we are working on a business case that's working its way up the food chain. So probably later in the year, we might come back in touch with you again, just in terms
Yeah,
of maybe helping
but
to.
we should make sure it gets in as part of the National Rare Disease Plan, which is due for publication in September. So let that be one of the pieces that
Mm.
gets implemented over the course of the next government. That we
Okay.
actually
Yeah, yeah,
we'll line our ducks up. But I'm not sure everybody else needs to hear all of that conversation, but we should definitely be talking about that, because that is
sure.
one of the areas where I would say that, advanced therapies and transplants
Mm.
and things like that, that we should be doing it in Ireland, where we have the resources and the skills and stuff.
Sure.
That,
Because, diagnosing these conditions is so important, but it's important once you diagnose a condition that you have the wherewithal to treat it.
yes,
And at the moment, we're lucky, we have access to the UK for that, but we may not always have that. I mean,
yes.
the NHS is coming under so much pressure,
Yeah, 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 yeah.
and
And
we
and
have.
actually, out of interest, I slightly digress from newborn screening. Transplant, do we have, how would we find donors, I guess, is my question. For such a small population in Ireland, is this a European donor bank that you're looking to, or how does that work?
Yeah, so I mean, there is a transplant program in Ireland
Yeah.
already for malignancies, and if you need a transplant in Ireland, you can find either a donor within the family, or the transplant unit will look to international donor registries. So uh, the transplant centres would have access to a donor registry that would have donors from across Europe, North America, predominantly, in other countries too.
Okay.
So in general, Irish patients in general don't have too much difficulty finding match donors. Uh,
Okay. Okay.
so that's one thing, one advantage of being Irish is that you get around, I guess. So lots of the likelihood of getting a good match is
Is
pretty high. And even if you don't, there's lots of clever techniques now
okay.
to allow you to use someone who's not a fully matched
Not a
donor.
perfect match. Okay. Well, that's
So I think going forward, there's more and more expertise coming back to Ireland. We've two transplanters now, and
yep.
one of my colleagues just came back last year. She's transplant trained, so we just need a couple of other uh, pieces of the jigsaw to be in a position to
To
offer
do
these
it.
treatments
Yeah.
here in Ireland, because, as you said, traveling to the UK can be very onerous for families.
Yeah, yeah, yeah. Well, I think when we see some of the cross-border stuff that is happening, and we should keep them in mind for this as well. In terms of I guess congenital heart disease, they always say the fact that we can get into a car or into an ambulance and just go down the road rather than
Mm.
flying, it makes the world of difference to
Sure. Yeah.
everybody involved.
No,
So it only just makes sense.
it is
Absolutely.
difficult for families. So we'd really like to move things along, because the more once you screen for a condition, we do have a responsibility to
Yeah.
have the treatment pathway. So the more we can do here, the better.
Absolutely. Anyway, listen, to those that are online, let me just get back to some of the nuts and bolts. This is all about Get Rare Aware, the campaign. We do have a website, getrareaware.ie, and we are asking everybody online and your friends and your family to get Rare Aware. Take a look at the website, getrareaware.ie. It'll teach you a little bit more about the newborn screening system, but more importantly, there's a take action opportunity, and we are asking everybody to please take action. All you need to do is to identify what part of the country you're living in, and insert your name and email address, and it will automatically send an email to your local elected representatives, or to the elected representatives for the health region that you are living in, and ask them to please get Rare Aware to, I guess, press the government for resources to allow expansion of our newborn screening system. It is really important, I think, as Ronan has said there, you know, the outcomes for our children, the fact that they're avoiding maybe, you know, really, you know, illness before they're eligible for transplant in Ronan's case. You know, it makes such a difference to families and to affected children. And it really is important that we do identify and you know, diagnose children as early as possible and give them the access to the treatment so that they can, you know, live their best lives, that they and their families aren't in and out to Crumlin or Temple Street, or I guess St. James's in the future, you know, that would get as many of those people off the roads and just being home and living their normal lives like we all aspire to, I guess. So please get rareaware.ie, take action, and I want to thank everybody for coming along today. There will be more webinars in May and in June. So if you want to hear more about this topic, or if you want to listen to any of the other webinars, please do join them. They're on the website. And we look forward to, I guess, raising the voices of the rare community amongst our elected politicians, particularly in the run up to election time. And you know, we need to keep ourselves front and center for them, or with them, so that we can really affect some of the changes that we're looking to affect over the next number of years. Thank you very much to everybody for listening in, and thank you in particular to Ronan for coming along today and really providing us with that incredibly interesting perspective on the newborn screening system. Thanks a million, guys. Take care. Thank you, Ronan. Bye-bye.